Good evening, doctors. Welcome to another episode of Nationwide Augmentation. This episode will discuss answer of the case 97, which was posted 2 weeks back on cghsclinics.com, and we'll also present an approach to patients with headache in wellness center. This is not going to be an academic lecture, so some of the aspects of headache are left out. But this presentation has been designed specifically for what we encounter in wellness center. So it is going to be a practical approach and not a truly academic lecture in coming 20-25 minutes. Please listen to the presentation first, and after the presentation is over, everybody can discuss and add to the discussion. So normally whenever a patient of recurrent headache comes, there's two commonest things which come to our mind is because of chronic sinusitis, and one is because of the refractive error. You immediately think about these two causes in wellness center. But remember, one of the statement made in the British Association of Study on headache in 2010, they say these are not very frequent associations with headache, and we need to go beyond these two causes. So we are going to see how we are going to approach patients of headache in our wellness center. So whenever a patient of recurrent headache or maybe an acute headache comes to you, the first and the most important thing that you look for is any red flag signs in that patient. And so what are these red flag signs? Any headache which is sudden in onset, severe in intensity, or any fever, meningism associated with headache. Especially in pensioners, if they come with a headache and the wife tells you that he is not behaving properly, or if you observe during examination, if there are acute changes in the cognitive function of the patient. Any patient who is immunocompromised, either because of HIV, cancer, or uncontrolled diabetes. Glaucoma is also an important cause of headache. It's important because the patient's eyesight is at stake. And less often we will encounter this altered sensorium patient coming to us because they might be going to emergency to nearby hospital. Now the second thing I do is, whenever a patient describes a headache, is it a secondary headache? Is there any cause for the headache? So if you on examination, neurological examination, find focal signs, for example, any ocular nerve palsies or hemiplegia or any neurological sign which suggests a focal lesion, then this is likely to be a secondary headache. Any patient who complains of headache who is more than 50 years old, so this is where our pensioners come into the picture. First time headache after 50 years, not to be taken lightly. This is to be investigated as a secondary headache first. Any jaw symptoms like claudication, pain, which may suggest giant cell arthritis. So in our elderly population, this is the one which you should think first. Unusual aura or triggers. Now, aura could be scintillating scotomas, eye symptoms. This could be any other symptoms which are unusual for a migraine or other types of headaches. And if they are lasting for a longer period of time, patient could be having a secondary headache. And once these two things I have ruled out, or I have taken care of, then I think, is it a migraine? So any patient with a history of a recurrent severe headache, which is pulsating in quality, throbbing headache, unilateral with nausea and photosensitivity, in which the patient simply cannot work and has to lie down in a quiet environment, then it could be a migraine. So this is what you will probably information that you will require in assessing a patient of headache in wellness centers. There are other causes of headache which I have not included in the presentation. So we had two cases of headache actually. Case number 80 we presented long back, and she was if you remember, she was a ladies in 60s, where she had lost her son, and she came with a headache and giddiness to my wellness center. And during examination we found that the it was a query incoordination and cerebellar sign, but actually she was having a very subtle visual field defect which was later progressed, and we came to know that. So headache with such a focal sign, you would always find some secondary cause. And in this patient, if you remember, the MRI brain revealed a brain abscess, a huge brain abscess. So there was another case 90 very recently. Everybody remembers that actually this patient did not complain of headache as such, but heaviness in the head, which is recurrent, and which was associated with bilateral hand pains, incontinence history, and that turned out to be Arnold Chiari malformation, giving rise to raised intracranial tension. So from our archive, we can say that whenever there is a focal sign or any neurological abnormality, the chances that you'll find something on neuroimaging are very high, and most probably you may be dealing with secondary headache. So we again come back to the same warning features in the history that you should look for, is that is a new unexpected headache in an individual patient, which is rapid onset. If it is a atypical aura with a duration of more than 1 hour, if there is associated motor weakness, and if it is a aura in a female on a oral contraceptive pills, all these patients usually have secondary headache, and you should be very careful about these points in the history. Any patient child with a new onset headache, persistent morning headache with nausea, a progressively increasing headache which is becoming worse over weeks or longer, any headache which is worse in a particular posture or worsens with cough, uh, then you are probably dealing with some secondary cause. If the patient has a history of cancer and if he comes with a new onset headache, suspect metastasis. Or a new onset of headache in a patient with HIV infection, it could be because of some lymphoma, or most commonly fungal infection. So once you have taken care of all these red flag symptoms and worrying clinical observation, then you are left with a patient who comes in a recurrent history of headache. Then you should take history in a particular manner. That what you should record is, you should record the temporal profile of the symptoms, when it started, acute or chronic, how fast it is progressing, what is the typical duration of a particular episode, one episode of headache, how long does it last, how does it end, how many times he has in a day, and was there any previous attacks of similar nature. What are the associated symptoms? Is there a nausea, vomiting, or a photophobia? This could be meningism or a migraine. Are there any autonomic symptoms the patient is describing? And whether the headache interferes with the work life, and what kind of severity it is. So if it is a migraine, the patient will not be able to work. He has to lie down in a quiet place, and he will not like to have lights around. So this is very typical of migraine. So you have to inquire on associated symptoms. Then what precipitates that headache? Is it cough, posture, stress, jaw pain? And again, you have to also take care of the, or ask coexisting condition, whether the patient has asthma, hypertension, or depression. If the patient has asthma, then this is important from point of view of selecting medicines, because you will not be able to use beta blockers. If the patient has a depression, then the most if the patient has a migraine and a depression, then the drug choice will change. Maybe you like to use venlafaxine. So like that, you have to note down with what are the coexisting conditions. Now, in wellness center, you have very less time to examine. So you can't examine whole neurology in a particular patient. So what I have included is what things you can see in less than 4 minutes. Very rapid mental status. During interview, you'll come to know what the mental status is. You can ask the wife or the relative. Quickly examine eye, the ocular cranial nerves, second, third, fourth, and sixth, and look for any facial asymmetry or facial paralysis. Quickly ask the patient to walk across the room, watch his gait, is there any abnormality, and gently palpate his scalp. You can make patient lie down and check for neck rigidity, and don't forget to check his blood pressure. Normally, hypertension usually doesn't cause headache immediately unless it is very high, more than 220 or something like that, when you suspect subarachnoid hemorrhage. But usually, blood pressure rise in moderate blood pressure usually doesn't cause headache. It may cause some other symptoms. So we will listen to what our patient described in the case 97. So listen to her.
दौरान मुझे एक महीने से अभी मुझे सर में पिछले 1 महीने से मुझे अभी सर में दर्द है राइट साइड में और यही दर्द मुझे
So she is describing right side pain.
3 साल 4 साल पहले भी होता था और
Recurrent
अभी
for
1
3 to
साल
4
पहले भी
years.
हुआ है और वापस से स्टार्ट हो गया है और ये दर्द 10 बजे सुबह से 12:30 बजे तक रहता है और इसके दौरान मुझे आँख से पानी गिरने लगता है और जॉ लाइन्स दर्द करती हैं, नाक ब्लॉक हो जाता है, कान में भी दर्द रहता है और बहुत इंटेंसिटी, पहले तो इतनी इंटेंसिटी से दर्द नहीं.
So she is describing very typical uh, features that it occurs at a particular time of the day. It is recurrent. There was a remission for a year, and then again it has started. And it is associated with autonomic symptoms like lacrimation of the eye, and the severity is quite high. So then we are left with a, now this is what we will approach now, that patient who has a recurrent headache with a normal neurological findings. So this patient had a normal neurology. So common would be a migraine with or without aura. So if the patient has any of the two and plus one of the following, that it should be unilateral headache, pulsating in qualities, severe enough, uh, two of these, and then one of the, whether it aggravates with the activity or the patient has a nausea, vomiting during the attack, or whether the patient is showing light sensitivity. And the patient usually will tell you that I just have to go to sleep to relieve the migraine attack or headache attack. So this is very typical of migraine. Other type that you will encounter is episodic tension type. which usually is bilateral, not pulsating, and patient usually do work. It's not worsened by activity, and it is mild to moderate in the severity. Now, this is what our patient had. Our patient had a cluster headache, a very typical description of cluster headache, which is also a trigeminal autonomic cephalgia. So the patient will have very frequent attacks, very severe, but it will be quite brief, less than 3 hours. It will be unilateral and with autonomic symptoms like lacrimation of eye, nose. So our patient's diagnosis most likely from the history was cluster headache. So most doctors got this uh, diagnosis absolutely correct. So usually the cluster headache is a type of trigeminal autonomic cephalgias and usually affects the male with the ratio is 6:1, and usually in young 20s they're often smokers, and it occurs in about it comes in a clusters, last for 6 to 12 weeks, and once a year or 2 years. This is what typically described by our patient, and similar time of each day is what this description fits in the diagnosis of cluster headache. So our patient most probably had cluster headache, and of course the association of autonomic features of rhinorrhea or lacrimation, and it's a very severe and intense headache. So out of the primary headaches that we see, the commonest would be of course this is US data, the migraine tension type are the commonest, and if you see the incidence wise, cluster headache is not seen very commonly. So this was the of interest in this patient, and I am very thankful to this patient who allowed me to record her symptoms, and her history was sufficient enough to point to the diagnosis. I have not included drug overuse headache, which is probably not very commonly seen in our setup. So what are the other types? The paroxysmal hemicrania type is another recurrent headache with normal neurological findings. Usually it is a unilateral, lasting very short 2 to 30 minutes, occurs in 30s and 40s. And the most important differentiating point about this is this actually responds very nicely to indomethacin. So this is a diagnostic clue to paroxysmal hemicrania. If you give indomethacin, it responds to that. Now, there is one group of headache type is a short-lasting unilateral neurology form headache with conjunctival injection and tearing. The short form is SUNCT, SUNCT. And these are the headaches which closely resemble our cluster headache group of patients. So these are usually unilateral headache, but they come for a very short period of time, and frequency is very high in a day, more than 3 to 200 times per day. Occurs usually seen in men, and is refractory to treatment, and there are some eye symptoms associated with it. So how do we treat cluster headache? So the acute is always by the triptans group. Either you can give intranasal or subcutaneous. If the patient is in hospital, you can give them 100% oxygen. We actually could not get intranasal zolmitriptan. Our pharmacist could not get it. Then the prophylaxis is usually first line drug is verapamil in the dose range of 240 to 480 milligrams per day, and this requires ECG monitoring because of bradycardia it may produce. Second line it could be lithium, or you can use topiramate or melatonin. So these are usually the drugs which are used if you want to go for prophylaxis. Now, Coming to migraine treatment, which is we will see very commonly, the first line treatment of any acute attack is analgesic spectrum that you can use for starting from ibuprofen, aspirin, naproxen, and paracetamol. So paracetamol here is a analgesic dose, 1 gram, and second line, which is actually group of all triptans. Commonly, we use zolmitriptan and sumatriptan, but not to be used in patients who has neurological signs or any cardiovascular risk factors uh, in these migraine patients, which we call complications of migraine. If you see in the history or examination, don't use triptans. For nausea, you can use domperidone, metoclopramide, and of course, there are other options if it doesn't respond to above first and second line, naproxen or fixed dose combination analgesics. So when to give prophylaxis in migraine? So whenever there are attacks more than 3 in a month and the acute medication that you are giving is not effective, or if the attacks are more than 8 per month. So these are general guidelines which will make patient eligible for migraine prophylaxis. And if there is a disability despite acute medication, then you can use migraine prophylaxis. What medication are commonly available in wellness center is propranolol, amitriptyline. The dose is starting from 10, but you can go up to 100 milligrams. Gabapentin is available. The maximum dose you can go up to 1800 milligrams in divided 3 dosages. Flunarizine, 5, start with 5, you can up titrate to 10. And the Valproex, 250 milligram titrated to 1500 milligram maximum in 2 dosages. So most of these drugs cause some amount of dryness and drowsiness. Sorry, but most important thing is there is a evidence, scientific evidence that acupuncture definitely helps in reducing frequencies of migraine. So you can actually advise this acupuncture in patients who are not ready to take these medications or having some side effects. And it is the Cochrane review on acupuncture has proven that it is beneficial. So coming to treatment of tension type of headache, the acute attack, similarly like migraine, you can abort with all spectrum of analgesics. And if you feel that the patient needs prophylaxis because of there is more number of attacks, then treatment similar to migraine in the form of amitriptyline or mirtazapine or venlafaxine can be given. Now, so we are coming to the close of this presentation, but I'll leave you with clinical pearls for diagnosis and management of primary headache in adults is that history is the key to diagnose headache, type of headache, and that guides your management. So you must spend more time in two things, history and quick neurological examination. Look for symptoms, signs which points towards secondary headache, and watch for red flag signs which have been described. No neuroimaging is required in chronic recurrent headache with normal neurology exam. So you will get a lot of patients coming with outside advice, uh, requesting for MRI and CT brain, but usually they are of no use if the neurological examination is normal and in a patient who has a recurrent headache of a long duration. Migraine we are not able to diagnose, it is still remains underdiagnosed and undertreated. We have to not only look for the typical migraine presentation, but some atypical features, atypical presentation, and complicated migraine. If you have patients of recurrent headache, primary headache, consider giving prophylactic therapy, which will prevent many emergency visits, and patients will feel better once they take effect. And you must give a good thought to acupuncture, which is proven in a good review in Cochrane. It works in the patients of migraine. So there are certain points have been described and found out. Uh, I can post that in WhatsApp about what points they stimulate to relieve migraine and gives good results in some of the patients. So I come close to the presentation. If there are any comments, questions, suggestions, please go ahead. There are two important articles that I would encourage to read is the Canadian Family Physician article, which is there in our virtual library, and British Association of Study of Headache Guidelines 2010. These are all very extensive headache guidelines, a big document. It's very difficult to keep a track of different criteria for diagnosis of minor details, how to diagnose. But the presentation that I have made is probably cover majority of patients in wellness center. So if there are any doctors wants to add to the information on the presentation, they are free to add now. I'll unmute all doctors. They can ask questions. There are plenty of specialists available today in the discussion. They can answer queries from other doctors.
So, Dr. Subbalakshmi from Chennai.
Yes, madam, go ahead.
Regarding prophylaxis for migraine,
Yes.
is there any specification of the duration?
Okay. Duration usually described for and you don't suddenly stop the prophylaxis. You taper down the dose and enforce during the prophylaxis period, you ask the patient to undergo lifestyle changes required to prevent attacks. So he should be asked to prevent any triggers which he can prevent by by ensuring good sleep hygiene, diet, balanced diet, and not disturbing is much of a routine, and simultaneously carrying the prophylactic drugs. So 3 to 6 months is what they advise initially, but it can go longer also if you require. There are some questions coming in. Dr. Kamesh is making a point that besides acupuncture, homeopathy can also be considered. Patients have shown reasonably good response in our wellness center. So Dr. Kamesh, if you want to highlight more on that, you can go ahead. Or any other doctors want to add to the presentation. Any more questions? Any additions? So if there are no questions, I can end the discussion. Yes, Dr. Gehlot.
Hi, sir. Good evening.
Good evening.
As prescribed all the other sign and symptom,
Yes.
I want to differentiate one important point between migraine and cluster headache. Cluster headache is very rare. Migraine is very common. But migraine patient is, I think, motionless or sleepy or silent. But in cluster headache patient,
Yes.
is I think rocking and rubbing headache.
Yes.
And I think there photophonia and phonophobia both are presented unilaterally in
Yes.
cluster headache.
Yes.
But in migraine and headache, the photophonia and phonophobia are present in bilaterally.
Okay. Okay, thank you, sir. Dr. Gelo was adding point for differentiating migraine from cluster headache. It's an important history point that the signs are unilateral in cluster photophobia and whereas they are bilateral in migraine. So I think that that's a very nice piece of information Dr. Gelo has given. Any other doctor wants to add to the presentation? We have only.
So one last,
Yes.
regarding the role of ergot preparations, are they outmoded?
No, they are definitely used in acute attacks. But the problem with these ergot is they also cause nausea and vomiting. So they are discouraged as such in the guidelines. Most guidelines say avoid as far as possible, but they are one of the modalities to abort the acute attacks. And they also have other complications also. So in cardiovascular risk factors or complicated migraines, they discourage the use of ergotamine. Commonly, we have beta cap or propranolol in our inventory of medicines, and tryptomar and amitriptyline, and even flunarizine. A lot of people use as a primary prophylactic agent. But I think acupuncture is one which probably doesn't get highlighted that much. I will post a picture of those particular 3 to 4 points are there. One point is just exactly just above the bridge of the nose that they stimulate in acupuncture, and one is above the eyebrow, and others are around the outer uh, uh, the lateral canthus of the eye. So these are 2 points they stimulate in acupuncture, and I was very pleased to read about this Cochrane review on this. Usually they don't entertain much on the alternative modalities, but they have positively recommended acupuncture. So there is one more question coming from Dr. Kamesh. That besides acupuncture, homeopathy can also, okay, no. What is the outcome of prophylactic treatment in the long run, and how long it should be given? So this was what Subbalakshmi has also asked. Normally, what I do is I run it for a 6 months at one go, and once the patient is stabilized on that, I titrate it down and seek an opportunity to withdraw it completely. But if that does not happen, probably if the prophylaxis is working and you somehow you are not the disease does not allow you to stop, and if it recurs, then it is worth carrying it forward as long as the patient's symptoms are controlled on prophylactic treatment. Dr. Gelo, do you want to add anything on the duration of prophylactic treatment?
That is depend on the lifestyle. I think first is lifestyle is very important.
Yes.
So first is modify the lifestyle, sleeping habits, eating habits.
Yes.
Then prophylactic is taper slowly.
Yes.
Then minimum dose it maintain. Then continue the minimum dose.
Yes. Yes. So we always look for opportunity to stop and see whether the headaches come back. And if they don't come back, sort of the patient goes into a remission. So Dr. Kamesh is asking, is telling that I think in such resistant cases, some psychological factors should be elicited. There should be certainly some cause there. Yeah, certainly. If you have a migraine patient not doing well on prophylactic, and if there are new features seen, say the headache severity is worsening or some the character is changing, then we should certainly look for secondary cause. We agree with that observation. So we are coming close to the session. Thank you all for attending session. So take home points are history is the key. Rule out secondary headache. Actively seek red flag symptoms. Don't do neurological exam in recurrent headache with normal neurology, and diagnose migraine more frequently and consider prophylactic therapy. Thank you very much.